Hello, ladies and gentlemen. Um, should I say good morning or good evening? Welcome back to um, today's YouTube stream. So I don't know if there are people here, and I don't know if you can see. I don't know whether to turn on the ring light. So those online, please. Is this camera? Is this okay? I can barely see myself. Is this okay? Or I should turn off the light? Is the light too much? Okay. So since we just have two people on the live session, but I'm still going to go on. So most of them can watch the video later. Most of them can watch. Okay, someone said it's okay. Yeah. So if you missed this, don't worry. The link will still be available for tomorrow. So you can always click the link and then uh, follow whatever discussion we've had today. So we are looking at constipation. Constipation. If you don't have the Bible for if you don't have the Bible, please get it. Okay. If you don't have the Bible, get some of the Bible. It's very important. Eh, This is Omega Hour. Okay, so those who have the Bible should now open to the book of. They should open to chapter 19. So we are dealing with page 19. Page 19. We are dealing with constipation today. Constipation. So it says that in general, constipation refers to bowel movements that are infrequent or stools that are difficult to pass. So sometimes some stools can be difficult to pass because probably one, there is an adhesion, or two, there is a lesion at the perianal region. Okay, there's a lesion in the rectal region. That is why it is always very important. It's very prudent to always perform a digital rectal examination for every patient who has constipation. This will save the patient a whole lot of stress and then cost. So once you perform a digital rectal examination, you'll be able to, if there's a mass over there, a hemorrhoid that is blocking uh, the stool, okay, is blocking the stool. With your digital rectal examination, you'll be able to pick it up, okay. Sometimes there might be other things that are occluding the perineal region. There might be some mass over there. So once you perform a digital rectal examination, you'll be able to pick it up. Okay. There was once a patient I attended to, an old woman who they brought to my facility at Tema. And then this old woman had hemorrhoid, I think four, stage four hemorrhoid, and had constipation. And she was in pain, screaming, screaming, screaming. Ah, Initially they had taken all sorts of medication, but nothing was happening. And it's this job is difficult to even tell an old woman. She's about 90 something years, but a little active. That you want to. I wanted to perform, a digital rectal examination. I wanted to just see what is there, and she was saying no, she wouldn't allow me. So I asked the daughter, "What is the mother having any form of hemorrhoid?" And she said, "Oh, what is hemorrhoid?" I said, "Oh, the aya mo friend no no." And she was like, "Oh yeah, me mama will be." And I said, "See, a pie." And so once she said that, I knew I was dealing with um it was the hemorrhoid that was causing the obstruction. So there are many things that can occlude the the anal region to obstruct the outflow of stool from the gut. Okay. So with the definition, they said in general, constipation refers to bowel movements that are infrequent or stools that are difficult to pass. So stools that are difficult to pass, we are looking at impacted impacted feces and all those things. They are all difficult to pass. Okay. Without wasting much time, let's go on. There is great individual variation in the normal bowel habits, and that is true. Some people poo poo twice a day, some people poo poo once a day, some also poo poo every 3 days, they poo poo once. So if such a person comes to you and says, oh, um, I've had constipation, let's say if the one that goes has been going having frequent stools for every day, he passes loose like normals to every day, each and every day. When such a person presents to you with constipation, then you need to take it seriously. But some people, especially ladies, they're able to keep, for some strange reason, they can keep the stool for like 3 days before they go. So such a person, if you ask the person, oh, and then wait to me call private, he'll tell you, oh, they be, and now to me call, they'll tell you, oh, they be 3 days ago to me quiet, they'll tell you, oh, they be. Then you too know, you quickly jump that when you're constipation. Then you start giving your lactulose and you start giving your glycerol and the rest. No. So you need to ask them if that is their frequent stool. That is how they've been having their stool in 3 days, 3 days, or 4 days, 4 days. If that is their natural way of having their stool being passed, then it's a normal thing. But if it is not, then you need to investigate. So if it is not, if um, that is how they pass their stool, all you have to do is to just encourage them to take more raw fridges, more water, and then about 3.2 liters and every day, and then about 3 liters every day is fine. And then you also encourage them to eat more raw fridges, and I think they are good to go. Okay, so diarrhea alternating with constipation may indicate a large bowel cancer, and that is true. If you've ever encountered some of these cancer cases, you may probably have noticed that um, most of the times they come with, today they come with diarrhea, tomorrow they come with constipation, tomorrow next they come with this, tomorrow next they come with that. So you need to consider all those things. So when an elderly person who is about 40 years old or more comes to you with diarrhea alternating with constipation, or they come with constipation, first you need to find out if the person is a woman, you need to find out if the person has a uterine fibroid. If no, or has some previous history of that. If no, then you also have to find out if they have any perianal mass. If they say no, then you also have to look out for diarrhea alternating with constipation, and that is very important. Even with such condition, you may have even have to rule out retro and all those things. Yeah, it's very important. Yeah. Okay, so um the usual the habitual use of laxative is very common in the in the community where people have diarrhea. I don't know. Hey, is everyone? Oh, okay. There are people still like, yeah. So sometimes those who use laxative for a very long time, because they always use laxative, their their colon assumes the their colon gets used to laxative before poo. So there are times if you don't take the laxative, um, the stool will not come. And then prolonged use of all those things can cause dilatation of the colon. Okay, we'll get there. There are many causes, many conditions that can cause dilation of the colon. Even hyperthyroidism can go a long way to cause all those things. And I'll try and explain all those things to you people. Okay. So, what are some of the causes of constipation? We have uh, diet deficient and roughages. I think I've said this already. Ignoring the urge to poo poo, and then hypothyroidism, and then hyperthyroidism to its part, but it's not in the book. Hyperthyroidism to its part, and I'll explain that. Especially those of you who have more information about hyperthyroidism, I'll once I explain, I'm sure you get to understand the physiology behind that. And then we have irritable bowel syndrome. We have hypercalcemia, and then drugs. So the use of drugs. This drug, how do you call it? Loperamide. It is an opioid. Loperamide initially was that's collodium. Initially, they were using loperamide for to control pain. Then they realize that it has a side effect of constipation. Those of you also are used to using morphine, injecting, giving your patient morphine, whether 10 milligram or 5 milligram, you may notice that sometimes they also come and then they report with constipation. It's a normal thing. It's a side effect of those drugs. So there are many drugs, especially the antidepressant medication, the TCA. So if you have a patient who has dementia, and then you put the patient on all those drugs, they are likely to present with constipation, and it's normal. So all you have to do is maybe you optimize the medication, try to maybe probably reduce the dose a little, or you try to change the medication. Yeah, if there are other alternatives. Okay, so we have lazy bowel syndrome. So lazy bowel from chronic laxative use. That is, I think that's the last but 3 points. Lazy bowel. So once you use, um, how do you call it? Laxative. Okay, when you use laxative for a long time, your colon becomes very lazy, and so your stool will not be coming. You will not be able to pass through by yourself unless you use laxative, because it affects the parasympathetic nervous system, and those nervous system is in connection with the vagal nerve, cranial nerve 10. I think yesterday I said something about that. And so those nerves, they actually work when you are less active. Parasympathetic nerves work when you are less active, and then the sympathetic nerves work when you are active. Okay, like by now I'm supposed to be in my parasympathetic state, being asleep, but I'm here in my sympathetic state, and we are all doing the omega hour together. So that's fine. And so lack of exercise can also cause constipation. Dehydration and starvation is also another cause of constipation in children. And it makes sense because your stool, before your stool will come out, you need it needs to be mixed with water a little before it will come out. So when you study the laxative, the types of laxatives, we have the bulk forming laxative, we have the osmotic type of laxative, we have there are four types. I don't remember the others, but if I remember along the line, probably I'll share them with you. There are others. I would have googled this, but I'm using the same phone for the live video. So so let's look at the surgical causes of constipation. So you are looking at gastrointestinal obstruction. So gastrointestinal obstruction, this one is a partial or total arrest or total cessation of gastric contents such as gas, fluid, and feces. These three things, they are the main gastric contents. There's nothing else in the there are not there's nothing else that is the gastric content again in the gut. It's gas, oxygen, did I say oxygen? Gas, stool, and then fluid. Okay, so those are the main gastric contents. Those are the main gastric contents. Okay, so sometimes there can be anal fissures and other painful perianal lesions or perianal mass. I think I've spoken about that. And then we are looking at colonic cancer. So in such a patient, you need to do a sigmoid, um, a cancer in the colon, a carcinoma of the rectum, and then the sigmoid colon. So with a sigmoid colon, you need a sigmoid sig. Uh, okay, so if it's a normal colon, it's colon. Hey, how come I'm confused? God of God, Satan of confusion out. So, colo. Hey, so someone should help me out here. So if someone has inflammatory bowel disease, Crohn's disease, colonoscopy, right? Colonoscopy. So sigmoid, hey, sigmoidoscopy. I think, yeah, sigmoidoscopy. Yeah. So, if there's a colon sigmoid cancer, there's a cancer in the sigmoid region, then sigmoidoscopy. I think that should be the right thing. I'll look for it and then probably type. I'll look for the real thing and then type it. So also foreign body in the gut. That one too um, can cause constipation. Also, pelvic mass, uterine fibroid, and then fetus. Fetus can also cause constipation. Is one of the most. Uh, it's also a cause of constipation. And then we have the aganglionic and then acquired megacolon. So megacolon is a dilation. Okay, someone just helped me out. All right, is that what? Sigmoidoscopy, okay, and then colonoscopy. Oh, thank you. So that's what I've been struggling to mention. So megacolon is simply is a dilate is a condition, is a medical condition that comes about as a result of dilation of the colon. So when the colon dilates, it leads to paralysis, and then it prevents peristaltic movements in the gut. So it's also very important. Megacolon, megacolon. Also, pseudo pseudo bowel obstruction. Pseudo bowel obstruction is almost the same as is similar to megacolon. Just as pseudo bowel obstruction is also the dilation of the bowel, which is not caused by mechanical obstruction. We are looking at mechanical obstruction. We are okay. So with the obstruction, you have physiological causes of obstruction and then mechanical causes of obstruction. I will take everybody. I'll take all of you through some of the causes of mechanical obstruction and then physiological obstruction. Uh-huh. We'll go through that. And then, so what are some of the symptoms of constipation? Symptoms are what patients say. They are what patient tells you. So they would come and tell you that they are unable to, have to pass through. They will also come and tell you that their stools are usually very hard. Okay, their stools are very hard. They also say they strain to pass through. Some of them will even come and tell you that they get some blood when they use the tea roll. So, and then some of them also tell you that there is usually an incomplete when they pass to or when they go to the pupil, or how you people call it. They tell you that it is incomplete. They feel that there's some still there. So the incomplete state causes colicky abdominal pain. Sometimes you have colicky abdominal pain because of constipation. And so colicky abdominal pain, we all know how it feels like. It's very uncomfortable. It will more now wall back. It will more now wall back. And so that one it's very unbearable. Okay. So what are the signs? How will you know that this person has constipation? So there's frequent high pitched sound. So you all know where to listen. When you are auscultating, around the periumbilical region. You can auscultate just a little towards the ileocecal junction. The ileocecal junction, if you know the how do you even call it? It is about 2 centimeters away from the umbilicus down in an oblique direction. So if this is, I don't even know how to even explain. I can't use my own self either. So if this is your, you know where the appendix is, right? How do we call the appendix, the location? It's called the. So when you locate where the appendix is, the ileocecal junction is slightly above that place. So that is where you can put your stethoscope there, and then for some time, and then you wait to examine, and then you are likely to also hear what a high pitched sound. It's because the air in the bowel will be moving up and down, so you are likely to hear a high pitched sound. But if you listen and you don't hear any sound at all, you don't hear any sound at all, then it means that you are probably dealing with a you are probably dealing with um how do you even call it? Oh, there's this condition after surgery. There's the intestines doesn't really, the bowels don't want to work. They don't want to. After surgical operation, the paralytic ileus. So that is one, paralytic ileus. It happens most of the times when you touch the bowel. When you do an exploratory laparotomy or any form of laparotomy, and you touch the bowel, or you do a surgery that involves the bowel. Once you touch the bowels they become alert. So they don't operate for some time, and that can cause um, constipation. Yeah. So with such a case, paralytic ileus, when you auscultate, you won't hear anything. The bowel will be silent. There'll be, absent bowel sounds. But if it is not paralytic ileus, the bowel sound is usually high pitched. So this is two things. If it is paralytic ileus, the bowel sounds will be absent. It may be absent. But if it is a normal constipation, the bowel sounds will be high pitched. So constipation is high pitched. Okay. So in case you listen, I'm sure we've all done physical examination and all, so we know where to look for bowel sounds and all those things. Yeah. So I'm sure you'll find it. It should just be the periumbilical region. You just you listen for some time, about 30 seconds or something. 1 minute is too much. Uh-huh. So also there can be tenderness, there can be rebound tenderness, there can be garden tenderness, uh um there can be tenderness, general tenderness all over, and this is a sign of peritonitis, sign of an acute abdomen. So you when that happens, you need to suspect a gangrenous bowel. So if they tell you that, the person tells you, one, I've had constipation for a long time. What happened? Oh, on to me go toilet for some time. Okay, fine. For how long? For about 5 days now or 7 days now. Okay, fine. If that's the case, let's auscultate. You started auscultating. No, you try to touch, and then the patient started screaming all over. That should tell you that the bowels are affected, and it's likely to something that is mimicking peritonitis. It means that there is probably a gangrenous bowel. The bowel has become gangrenous. So you need to leave it to the surgeons to deal with it. So investigation, they said digital rectal examination. And those of you who have been using this finger for children, please don't do it. It's a sin. How can you use the middle finger for children? That's very bad. So when you are to examine a child with suspect intestinal obstruction or something, you want to examine the perianal region or do um, a rectal exam, you use the pinky, you use this one, okay? You wear like two gloves and then you put a lubricant on it. If you don't get lubricant, you can use the normal saline or normal water, and then you stick your finger in there and then you move it, 3 o'clock, 12 o'clock. So you sometimes if you put your finger there and then you remove it, the stool can splash on your face. So any of the packages that comes, you need to accept it. After you are being paid for it. So if it splashes on you, you take it like that. Okay, so another investigation you need to do is stool for occult, stool for occult blood. Yesterday, was it yesterday or the last time we had the first meeting about on gastroenteritis? I spoke about stool for occult. So once you do stool for occult, you are ruling out malignancies. Once you do stool for occult, you are ruling out malignancies. So if you do the stool for occult and it comes, they said there is no occult sin or whatever it is. That is it. But once you do stool for occult, you are ruling out malignancy. Okay. And then they said what? Plain chest x-ray. Sorry, plain abdominal x-ray. That is what? Erect and supine. The reason why many people fail, you see constipation case on uh, being MDC, though drop constipation question and say, oh, wait there, fala. They'll tell you, give an investigation you carry, then someone will go and write ultrasound scan. Unless maybe they tell you that there's garden or there's you want a differential of an appendicitis, that's fine. But once they say constipation, no, x-ray, plain x-ray of the abdomen, erect and supine, erect and supine. Once you do that, when you do an x-ray of the abdomen for constipation, you're looking for hostration. Hostration is, the colon, the how the zigzag, how it looks like, it will show over there. We call it the dilated bowels. It has dilated into, when you do the x-ray, it will show. Okay, dilated loop of bowel, very important. And then you also be looking at the diaphragm. You're looking at air under the diaphragm. Air under the diaphragm indicates that the something has ruptured. So it can be maybe the appendix, it can be anything. You're looking at that. You're looking at um, apart from that, I think that's the main thing you look at when it comes to erect and supine x-ray of the abdomen. That's the main thing in connection with constipation. That's the main thing. You're looking at hostration. Hostration is the zigzag portion. How the bowel looks zigzag. Is called hostration. But the appearance of the bowel on the X-ray, the abdominal X-ray is called the dilated um, loop of bowels. I know many of you know more than me here. I'm a student. I beg. I won't do that again. I'm also trying to learn from you. So if you know many things you can find on the abdominal X-ray, please kindly drop it in the comment section so that I can also learn something from you. Okay. After all, I'm not a fountain of knowledge. I'm also learning. Okay, so you can also do proctoscopy. Procto Proctosigmoidoscopy. This is what I've been fighting to pronounce. Colonoscopy and then sigmoidoscopy. So those are the things you can also request for. You can do to satisfy your curiosity. That is, if you are suspecting uh, a malignancy. So if you are treating a patient in real life, you don't go straight away and do proctoscopy or sigmoidoscopy. I beg. In normal life, you are suspecting any malignancy, please, you can just request for stool for occult. If it comes and it is positive, then you can go ahead and do your proctoscopy or sigmoidoscopy. Okay, or yeah, yeah, that is it. But when it comes to exams, okay, every intestinal obstruction case or um every case that will involve surgery, every case that is likely to involve surgery, you need to do BUG and creatinine. You need to write full blood count. You need to write BUG and creatinine. Why? Because no surgeon will perform on a patient whose creatinine clearance is bad. That's one. No surgeon will perform on a patient who has severe anemia. That is two. So these two things you can't remove it. So when it comes with surgery, we haven't gotten there yet or done anything surgery. But when it comes to surgery, any case like that that will involve, if they can't tell you, oh, intestinal obstruction, what is your diagnosis? Intestinal obstruction or hernia, something, something. Pay. Every surgery, it means the surgery will be done, right? So you make sure you put your friend is saying BUE and creatinine. You make sure you put full blood count. It works for all surgical cases, all and almost all apart from bone dislocation and fractures, all of them, you will need an ultrasound scan. Almost all of them, unless it has not got to do with bone, unless it has got to do with bone, almost all of them, if you can write how do you call it, ultrasound scan. And the reason why most people don't make it during the MDC, there are good people. I particularly know one of my seniors, very intelligent. I think right now he's in UK or something. He wrote it and he didn't make it, and we were all sad. Practically me, I was very sad because that was my role model back then. And so sometimes you may know all, but you might be lacking a few things, and those things, the nitty gritties, are what they actually require. So don't go and write any lab kesiye biya. When they start intestinal obstruction, hey, how do you call it? Constipation. What you are looking at right now, there'll be uh, fluid is not moving in, fluid is not moving out. So what should you monitor? You can monitor the urine output. What should you do? You have to pass NG2 to decompress the abdomen. Those are the things. When they tell you how will you manage this patient, it doesn't matter what they are asking for. When they say how will you manage this patient, one, assess airway for patency. It doesn't matter with the question. Oh, if you want to survive, one, assess airway for patency. Two, ensure breathing. Three, ensure circulation. Four, if it is a traumatic case, you can say assess pupil for dilatation. And that one works for substance abuse or unknown substance injection. Maybe a child has swallowed paracetamol or something, or an opioid, anything. So you need to, for that one there, you need to, assess pupil for dilatation and all those things. If it is a traumatic case involving the head, cervical spine support, all those things, or assess the spine, assess the spine for cervical spine alignment. I'll look for the right thing to put it. Ensure cervical spine alignment. I think this is perfect. Uh-huh. Before you come and say you take blood sample for laboratory investigation, over there, no, you won't tell them any laboratory investigation you want to do. I'm using this opportunity to pour my heart out because I don't want anybody to rewrite anything again. This year is your year. Okay. Uh-huh. So cervical spine alignment. If it is um any lab thing, also pay attention to the vitals. Very important. This whole thing can change if they tell you temperature was 40 degrees, or they tell you temperature is 40 degrees, you are no longer thinking about intestinal obstruction and the why are thinking about peritonitis and something dangerous ahead. So sometimes you have to pay attention to the vitals. And as part of your plan, as part of your management, if temperature is already high, you have to say control temperature with an antipyretic. Don't mention anything. Don't go and say anything before maybe you paracetamol. You end up spelling the paracetamol wrongly, and then they'll come and mark you down. Don't antipyretic. If oxygen saturation is low, you have to put on all these things. They intentionally put those things there as trap. They are traps. Those things are traps. So they intentionally say SpO2 was 85%. They are trapping you. So 85%, quickly you circle that 85. Temperature of 39 point something. Quickly you circle that temperature. So you put it in your plan. A temperature of this, you have to control temperature, you have to control wine. Okay. So now if they tell you that in a case of this, a case that is likely to go to theater, you have to insert what? Two large bulb cannulas. It helps the anesthetist, okay, and it helps the surgery to go on smoothly for the surgery to go on smoothly. Uh-huh. Okay, so let's go on. So in a case like this, you have to, pass NG tube, a case of intestinal obstruction or something. Okay, you have to pass NG tube. After you have examined the perianal region and all those things, you pass NG tube to decompress the abdomen. You set IV fluid for adequate rehydration. Okay, and then if the patient is in pain, you put the patient on an how do you call it? Is it antipyretic? No, antipyretic is for fever, right? So you give analgesia. You give an adequate analgesia to reduce the pain. Uh, okay, so let's go on. Treat, if you have the book, you open. Oh, if you don't have it, there's a soft copy. There's a soft copy. So I'll look for a way and then send it onto the page for those who don't have the book. But this book, you need to go and buy it. If you go to Kolebu, you get Kolebu book something. You get it. There are shops, you get it. Actually, I don't sell some, so I don't know how it is. Me, I store it from my facility. I'll go and put it there tomorrow. So, so with the management, you identify you identify possible causes of the constipation. Like I said, if you know the cause of the constipation, then it's simple. If it is whatever it is, once you do the DRE, you'll be able to find whatever it is and then you deal with it. Okay. So right now, no, we all know any constipation case or intestinal obstruction case, full blood count, BUE and creatinine, X-ray, plain abdominal X-ray, erect and supine, erect and supine, erect and supine. If you remember anything, erect, erect and supine, erect and supine, erect and supine. Okay. So plain abdominal X-ray, erect and supine, because you have to be in supine and then erect. So it's another way of remembering it. So erect and supine. You need to lie down supine, and then you need to be erected. Erect and supine. Okay. So we all remember erect and supine. So the non-pharmacological management, your adherence to regular exercises, and those things are important. When you excite the nerves, they also work. They also work, especially if you don't exercise, the nerves, those vagal nerves, they are also lazy nerves. Okay, they're also lazy nerves. They won't work for you. Okay, so adequate fluid intake is also one. So if you have a patient with an acute constipation, you only advise, maybe they came with constipation of a day's duration, 1 day's duration. You advise them to take more fluid. You advise them to take in more water, and then more fruit juice, more of roughages like cabbage, carrots, and all those things. Yeah. So all those things they promote motility, of the bowel. Yeah. Okay. So let's move on. Let's move on. So what are the management? Actually, me management of constipation. I have like three drugs I normal naturally I use even at work. When I'm working on a normal day, I have three drugs I use, and I don't use the other ones. I have not tried it before, but if you have tried it before, you can put it in the comment section. Me, I personally haven't tried it before. So I have tried Bisacodil, and then I have tried lactulose, and I've tried glycerol. Glycerol works like magic. Glycerol, suppository glycerol, it works like magic. So if you haven't tried it on your patient, please try it. It works. It works like magic. For adults, dose is 4 grams start. For children, you can do 2 gram or 1 gram. But me, for children, I do 2 grams, and adults, I do 4 grams. Suppository glycerol, it works. So it's not really, you can't really find it in any of the pharmacies unless the patient roams. And so I use that one for stubborn constipation. Stubborn constipation where the family has financial constraints and all those things. Then I let them go and look for the glycerol. They insert 4 grams start, and then it will just come within some few hours. It will just come. Uh-huh. But you can use the Bisacodil, you can use the lactulose. Lactulose also work. Okay, lactulose is also one good um, medication. Uh-huh. But the STG has other medications which me myself I feel lazy to look at them because I am okay with what I have. I don't want to learn anything new. So they are saying the first line evidence rating C. They are looking at Bisacodil, that's 10 to 20 milligram at night. Normally, we give our patients how many? 15 milligram. That's 3 starts. Right. Okay. But you can do, but when it is MDC and they can ask you, say, Bisacodil. I'm not sure they can ask you the dose you are supposed to give, but in case they ask, you can. It's 10 milligram, 10 to 20 milligram. And then Sina. Please, who has tried Sina? Sina, oral Sina. They are saying 15 to 30 milligram at bedtime. Maximum is 70 to 100 milligram. If you have tried it, please share it. Just type something fast. Or if you have a picture too, you can drop it. Me, I have not seen some before. Still, I don't really know how it works. I only stick to the ones that work like magic, so that my patients can dash me things. Uh-huh. So Bisaquado these days, I don't even use it because it doesn't work like magic. So I don't really use it. So you can prescribe it to people, those old people that today they come with constipation, tomorrow they come with this, tomorrow you can use the Bisaquado. Also they have the paraffin oil, liquid paraffin. It's an oral medication, and that one too is 10 to 30 mils at night. That one too, I've not tried it before, but I've tried milk of magnesia. So milk of magnesia, I've tried it with children, and it works. That one too works. So milk of magnesia, 5 to 10 mils in a glass of water, 12 hourly. So 5 to 10 mils. That one too works. It works perfectly. It works perfectly. So, ladies and gentlemen, we have come to the end of today's discussion. I mean, today's discussion has been I'm not really in the mood, honestly, but it has to happen. I feel sleepy, but it has to happen for the sake of everyone. So the criteria for referral, they are saying the following categories of patients should be referred to a surgeon. That's a patient with absent bowel sounds. Now, what did we say about absent bowel sounds? We said when bowel sounds are absent, it is likely to be paralytic ileus. Okay, and when they are high pitched, it's likely to be what? It's likely to be. Please drop the answer. Okay, so when there is vomiting, vomiting or not passing of flatus, and then when there is what, resistant, when the patient is resistant to the medication. Okay, okay. So we have come to the end, but you can drop questions. If you have any question, you can drop it in the comment section, and then I will address it all. Yesterday, I realized I didn't put that option available to answer questions. So if you have any question pertaining to this discussion, you can drop it so that we look at it. Maybe if I've forgotten something too, you can re-school my mind so that I can um, reflect, or okay, I'm waiting for questions. I'm waiting for questions. Okay, so there are other things that I haven't said, and those are some of the mechanical causes of intestinal obstruction. And so we are looking at hernia, we are looking at adhesions and bands, we are looking at intussusception. Okay, intussusception, we are looking at volvulus. Okay, volvulus. So intussusception, how we diagnose intussusception, when the child, the mother, the mother tells you that my baby has been doing this. Let me show you. I've forgotten the name we call it. So when they lie down, they do something like this. Okay, they bring their legs closer to their stomach. Okay, so that is one sign that is intussusception. And when they tell you that when their children poo poo, the stool looks. I'm still waiting for questions, so that's why I'm saying all these things. When the children poo poo, the stool looks jelly. When the stool looks jelly like, that is likely to be intussusception. And then you can also ask the mom if they have been using enema. Okay, they've been inserting that thing at the buttocks and pressing. You can also ask the mother if they do that. So if they've been doing that, then the child is a candidate for intussusception. And intussusception, children who fall below the age of 2 years have high risk of developing intussusception. Hey, is it 2 years? Hey, that's something crazy. I'm forgetting everything. So, but I think it's 2 years. I think it's 2 years. But you can also cross check and then let me know, because the those are the children who are struggling to adapt to normal life. And then I think volvulus too, it happens. It also happens to children below 2 years. Yeah, that is because that is the time mothers try to switch food from baby food to adult food. So at the end, the intestine twists. Okay, so that is volvulus. And then so volvulus comes with vomiting. So with volvulus too, with your sharp clinical skills, if you examine, you should be able to pick it up, especially when the child is a baby. I mean, a child is a baby. That doesn't make sense. When the patient is a baby, uh-huh, you should be able to pick it up. So it's not all vomiting and things that is acute gastritis and all those things. There are other causes. So you need to like take your history very well. And what again? I'm waiting for questions. So I'm waiting for questions. I'm waiting for questions. Um, Okay, so fibroid, uterine fibroid, gallstone ileus, gallstone ileus. So that one too is possible. Gallstone, it can it can cause constipation. So that is gallstone can cause, yeah. Uh-huh. Okay, I'm waiting. I'm waiting. There are many causes of constipation, like thousand. But we can't remember all, Charlie. Confirmation Subaye. Okay, we are waiting. So you can put the question there. Hey, no question. In in the absence of any no question there, then I means I have to ask questions. So should I mention names? Of course, I won't mention names. Okay. So I think we'll come to the end of this discussion. If you remember anything, don't worry, you can put it in the comment section. Maybe later, when I'm free, I'll still come and then go through and then see how best I can answer. Or maybe if anybody is there to answer to, that's fine. Then the person will also answer, and then we see how best to go about it. Anyway, thank you so much for being with me. I'm so grateful. I'm super grateful. All right. Have a wonderful evening. Bye.